Thank you for that kind introduction and welcome to my presentation for the online symposium. I'm going to be speaking today on strategies to improve hydration of residents with dysphagia in nursing homes. I'll be giving a brief overview of dysphagia, its prevalence, as well as characteristics of dysphagia, and then talking as well about the prevalence of dehydration and outcomes for persons living in long-term care. I then want to spend a bit of time talking about the strategies to support hydration in residential care settings, and specifically use a topology that was created several years ago now to think about how complex it is to address the challenges of oral hydration in individuals living in this setting. We'll talk specifically as well about dysphagia strategies for individuals that have that condition. So first off, the prevalence of dysphagia in residential care is actually quite variable. This is dependent on how it is assessed and of course where the assessment is being taken place. For example, we know that about 13% of individuals in Italian nursing homes have dysphagia based on clinical assessment. This is in contrast to a large variability identified in the Nutrition Day studies, looking at 19 countries, where again, the average is 13%, but is highly variable depending on how it was assessed and in what country. In the United States, a study done several years ago now found 8% of individuals were using thickened fluids. And this is in contrast to 35% of individuals more recently identified in Spain. This suggests that perhaps we're seeing an increase in the risk of dysphagia or the need for thickened fluids over time. And then finally, if we look specifically at dysphagia risk, which is individuals who might have choking or being on a modified texture fluid or food diet, in long-term care homes in Canada, the prevalence is actually quite high at 59%, with 11% being on thickened fluids. So it is very variable depending on how you determine an individual has dysphagia. If we think specifically about individuals with dementia, the prevalence is probably higher. And this is most individuals living in long-term care. So instrumental assessments identify that 84 to 93% have dysphagia, whereas a clinical assessment identifies that about 32 to 45% have dysphagia. And this was based on a scope and review done several years ago now. When we think about who are those individuals in residential care with dysphagia, they tend to be those that are most frail. These individuals have functional cognitive impairments, which are often quite severe. 84%, for example, might require eating assistance. They often have chewing problems and they're often at nutrition risk. As a result, we also see individuals with dysphagia more likely to die within 1 year as compared to those without dysphagia. As indicated before in the prior slide, we sometimes don't know that the individual has dysphagia, but they might be on modified texture foods or fluids. And based on that sort of criteria, we see also a variety of other risk factors. For example, poor oral health, increased risk of sarcopenia, as well as eating challenges and needing eating assistance. So these individuals in long-term care with dysphagia often are our most frail individuals. What is dehydration? Dehydration is basically greater water loss in the body than intake. So basically a deficit of water in the body. This results in increased osmolality in the extra and intracellular fluid spaces, which means that we have some challenges with respect to how our body works as a result. It's defined as a rapid decrease in body weight of greater than 3% due to the loss of water. And it's basically what we're seeing is increases sodium, which increases the osmolality in the plasma and reduces the intracellular volume. This is diagnosed in different ways, the most common being greater than or equal to 300 milliosmoles per kilogram serum osmolality, greater than or equal to 150 millimoles of liter of serum sodium, or a bun to creatinine ratio, which is greater than or equal to 20. So a variety of ways that we can assess dehydration. The outcomes of dehydration are quite diverse. It can be everything from simple constipation and maybe feeling a bit of fatigue to actually having renal failure, depending on the state of the individual with the dehydration. We see all of these sorts of factors and outcomes in the long-term care setting. So we think about hospitalization specifically that might result from dehydration. There was a study done in 2012 that looked specifically at individuals living in nursing homes and identified that 1 million of those individuals were admitted to hospital in the first year of their stay. And of those 1 million hospitalizations, 30% were what we would consider avoidable. And dehydration was one of the 5 most common causes for those avoidable hospitalizations at about 12%. In contrast, pneumonia was 27%, which is quite high, as you can see, for those avoidable hospitalizations. But regardless, dehydration is a very important and prevalent issue with respect to older adults living in long-term care. When we think about trying to find some statistics around that, specifically in the long-term care setting, it's quite challenging. Again, wide diversity, potentially because of the way it's assessed, but also the challenges with respect to different groups of individuals, different types of residences over time being looked at in terms of dehydration. However, key risk factors, quite consistent actually, quite frankly, with dysphagia, are that people having cognitive impairment are more likely to have dehydration. And we do see as well fever, which might be indication of an infection that's actually led to water loss in the body. A narrative review a few years ago identified that, or stated quite frankly, that up to half of residents in long-term care could be have impending dehydration, so very high risk for dehydration. And if that's the case, we really need to be thinking about considering almost all individuals to be at risk for dehydration in long-term care. So why are they at risk? Well, as we age, we have a decreased thirst for fluid. The way that our body senses thirst changes over time because of renal function, and people just don't state that they're thirsty or identify that they're thirsty and go looking for fluid. They also have a decreased capacity to concentrate urine, which means they're going to lose more water from the body as a result. They tend to have a lower fluid reserve because they have lack of lean body mass or lower lean body mass than people that are younger. You use many medications which require fluid metabolism in the body. And then there's a variety of other mechanisms that lead to decreased fluid consumption. And that's this typology that I mentioned at the very outset of this presentation. So in 2006, mentees identified a variety of ways that people might not be consuming enough fluid or hydration. And she identified 4 big groups: those who can drink, those who can't drink, those who won't drink, and then end of life. Looking at the first 3 groups, they could be subdivided dependent on some key characteristics. So those who can drink but tend to not have enough fluid might be independent. They're just not drinking enough, maybe because of a lower thirst drive, for example. As well, in the can drink group were those individuals, though, that forget to drink. So individuals with dementia specifically. Those in the can't drink bucket were those with dysphagia. So they have some challenges with respect to safely swallowing thin fluids, resulting in the inability to drink thin fluids. Also, physically dependent individuals will be in this can't drink bucket. These are individuals who need support from others to drink their fluids. Those who won't drink are sippers, those people that just drink a very small amount of fluid at any one time. We're not really sure why, but they just are small volume consumers. And then those who fear incontinence, so they don't want to drink. And as I said before, the end of life has its own specific circumstances with respect to lack of hydration. The dysphagia dehydration overlap has been studied, but not very much, quite frankly. So we really don't have a lot of evidence around the prevalence of an individual with dysphagia who then also has high risk for dehydration. And what is that prevalence? You're going to see dehydration in this subgroup of people in long-term care. It's been estimated from a variety of reviews that it could be upwards of 44% of individuals with dysphagia having dehydration. And this could be just chronic dehydration. We do know that people who do have require thickened fluids or have dysphagia, they have a lower fluid intake for sure, with only 7% meeting their fluid requirements as compared to about 33% of individuals who consume regular or normal thin fluids. When thinking about actually assessing dehydration, though, this is where the evidence is very limited. And a non-significant difference was identified, and 2 stats here that it was anywhere from about 2% or so for persons with who were on thin fluids versus up to 6% of persons on thickened fluids. But that was a non-significant difference as stated before. So we think there's a high likelihood that individuals with dysphagia have dehydration, but our evidence is quite limited. Why might individuals with dysphagia be at risk for dehydration? Well, back to some of those earlier comments, they don't have a thirst drive, and although the other physiological changes with age, because we know that dysphagia increases with age as well, right? So inability to sense thirst is one of the most common ones that we see. However, specific to dysphagia is that individuals may avoid swallowing liquids because they're afraid of choking. And so this results then in not consuming enough fluid in the form of high fluid foods, for example. As well, there's been some indication in the literature that individuals don't adhere to the thickened fluids they've been prescribed for a variety of reasons. Some don't like the texture itself, they don't like the taste of the fluids, or they just don't think they're acceptable in terms of quenching their thirst. Regardless, patient acceptance can be quite poor, unfortunately, for thickened fluids. In addition to those issues around palatability and patient or resident acceptance is the issue of home staff being able to prepare the thickened fluids. This can be anywhere from, I've seen it happen by nursing staff at tableside to dietetic staff doing it in the servery on a neighborhood or a unit, or down in the kitchen being prepared up to 24 hours before a meal. All of that can lead to variability then in those thickened fluids as they are being then consumed by the older adult. And that variability might mean less acceptance, one, but also potentially risk for choking and thus refusal, again, by residents to consume these fluids. There are pre-prepared thickened fluids that are available. The cost can be prohibitive to some nursing homes. Take, for example, in Ontario, we try to meet the requirements of individuals in terms of food and fluid, as well as oral nutrition supplements, on $9 or so a day, which is very limiting then when you think about high cost products, whatever they may be, whether they're oral nutrition supplement or a thickened fluid. So we have to limit often these high cost products. There's also the issue of residents' capacity to open the thickened fluid containers. They often come with some sort of a lid or some sort of wrapping, which can be limited to being able to remove that because they may have arthritis or issues with their fingers, lifting off lids. And then using a spoon to consume these fluids as well might be a challenge. People, it might seem unnatural, or they might have challenges trying to put the fluid on the spoon and move it towards their mouth and consume it. So lots of reasons why we might see dehydration in individuals with dysphagia. But in addition, think about the topology I just showed you. It's very likely that individuals with dysphagia might also be sippers, or might also be individuals with dementia who forget to drink, or they can't drink on their own. They require the help of someone else. All of these will be reasons why we see dehydration happening in individuals who also have dysphagia. So I'm now going to shift into thinking about strategies and how we can address dysphagia and try to mitigate the risk of dehydration or prevent dehydration in older adults living in long-term care and other residential environments. A key challenge, though, is there's a real disconnect between what we know and what happens in practice. In residential care settings, there often is a lack of capacity to do assessment, for example, with respect to dysphagia. There might be challenges with respect to enough staff to make thickened fluids and provide them, or there might be over concern about risk around choking, and that could lead to overly restrictive diets that could lead to dehydration. So there's this real mismatch between what we know and what's actually happening in practice. We have to remember that any decisions around diet textures, including thickened fluids, are life-changing for the resident and should not be taken without significant investigation, understanding of the need for those textures and thickened fluids. Thickened fluids are the predominant way of meeting the hydration needs of individuals with dysphagia in residential care. The ESSD standard came out a few years ago, and it helps to standardize terminology as well as consistency, and provided some simple testing methods can be used in any setting with respect to identifying if a fluid is a certain consistency. What we know is that when we thicken a fluid, it will slow the flow rate, which means then the body and specifically the swallowing mechanism is better able to control that bolus of fluid and swallow it safely without aspiration and penetration. There's been quite a bit of recent research in this area, and it's identified that thickened fluids do decrease the risk of penetration and potentially aspiration as well, and potentially pneumonia as a result. So it's definitely worthwhile thinking about thickening fluids to prevent aspiration and penetration of those fluids into the lungs. Thickeners as well, some recent evidence suggests they do not affect the water absorption, which is very important. We want to make sure that the fluid that's being consumed when it's thickened is getting to the individual and nourishes their body. With respect to our understanding of use of thickening fluids in long-term care, most people are on what we would consider nowadays an ESSD level 2. Now, this study was done much earlier than the ESSD criteria were put out, but approximately the majority of people that would be in long-term care are at that level 2 stage with respect to thickened fluids, or potentially level 3. We need to, though, think about what level of viscosity is really needed for the different individuals with dysphagia phenotypes. And that's a significant challenge in long-term care, as I indicated. There's a mismatch between what we know in terms of evidence and practice. There really isn't the qualified individuals in all settings to be looking at individuals with dysphagia and identifying the best thickened fluid for that individual, not going too thick. At this point, we need to remember as well that thickened fluids are not sufficient to address the issue of pneumonia. Saliva and bacteria that goes down through saliva into the lungs can also lead to aspiration pneumonia. So it is certainly one strategy to support swallowing safely, but people may still get pneumonia when on a thickened fluid because of saliva or food going down into the lungs as well. So it's really a complex mix of factors that result in aspiration pneumonia, building in oral hygiene, as well as what's already in the mouth and potentially causing aspiration pneumonia. Most recently, I did a study around thickened fluids, or I should say it was around hydration in long-term care. And one of the questions we asked was around a strategy of pre-prepared thickened fluids. This has been one noted strategy in the literature to try to overcome the challenges of inconsistency and making sure products are palatable so that residents will consume them. In an online survey of over 188 persons who were providers in long-term care and other residential environments in North America, we found some key results that I want to share with you. So when we asked them about the strategy of pre-prepared thickened fluids, 64% said they were very likely to improve hydration. 70% felt that they were very likely to be easy to use, and almost all said they were very or somewhat likely to use this intervention in the future. So this is an area that we certainly need to be thinking about with respect to ensuring standardized thickened fluids in long-term care, thinking about a pre-prepared product if it can be cost effective. We had a subsequent think tank for individuals that were experts in this area, as well as providers, giving a perspective across Canada with respect to their individual areas of practice and the challenges they saw with hydration. When we asked them about the issue of pre-prepared fluids and dysphagia, they said it was key that staff and family were educated on the need for thickened fluids. They understand why they're being consumed and why they need to be prepared the way they are, if they are being prepared in-house. They also talked about, though, that we should really consider normalizing thickened fluids in long-term care rather than making it the exception, thinking about how we can provide smoothies and other ESSD level 2 or 3 products that are normal for everybody in the home to consume. Also need to increase variety, especially for the ESSD level 2 and 3. And then think about adaptive vessels that might allow individuals to more safely consume fluid because it slows down the provision of a thin fluid to an individual, rather than only looking at potentially thickening the fluids. So these were some suggestions by recent experts in this last 6 months or so with respect to trying to think about thickened fluids and dysphagia in this setting. In addition to thickened fluids, there is the free fluid protocol that was actually developed for rehabilitation post-stroke. There's not a lot of evidence, though, with respect to this strategy. And what's key is that an individual must have a very clean mouth if they're going to follow the free fluid protocol, because as I just indicated in the prior slide, aspiration of oral contents, whether it be saliva or some food that's there, into the lungs can cause aspiration. So when we use a free fluid protocol, there's the potential that any water that's consumed would take down the microbes that are in the mouth into the lungs. And so you have to have an extremely clean mouth and really good oral hygiene. There has been suggestion from this research that is limited that it could increase the fluid intake and satisfaction of individuals. However, we don't know how it would work in long-term care. I don't know of any study that's been done actually in long-term care, but we do know that if it's given to individuals, the free fluid protocol is used in people with functional dependence or cognitive impairment, they actually can have an increased risk of aspiration. So in this one study I identified here, 14% got lung complications who were on the free water protocol. In long-term care specifically, there are challenges. So we know that oral hygiene is not optimal by any means. Teeth brushing and mouth brushing may not be an activity that happens every day for every resident in the way we would like it to happen. In addition, we lack speech language pathologists in Canada anyway, and in many other parts of the world, I'm sure as well. We lack that individual in that setting to provide a qualified assessment and capacity for the individual to follow a free fluid protocol. And then finally, you need to have sufficient staff to be observing and watching and providing that free fluid in a way that it's monitored so that the individual, if they do run into some challenges, support can be provided. And that's a challenge in long-term care. There is not sufficient staff with respect to providing eating assistance or hydration. So at this time, although it is a potential strategy, it's not recommended for almost all residents in long-term care because of these challenges of implementation. Some other strategies that you may not know of, and I just thought I'd touch on them briefly for you. We could think about textured thin fluids as a potential moving up from a regular thin fluid as a first step before going to ESSD level 2. There might be some individuals that can handle this, but again, we need that speech language pathologist assessment to be able to understand if that's successful or not. This would be things like tomato soup or a nutrition supplement. So things that can be consumed through a straw, quite frankly, very easily, would be potential fluids that we could try. These, there is a bit of research evidence suggests that they are better accepted than the thicker levels of thick fluids. Food is another potential vehicle for fluid. So there are many foods that we consume on a daily basis that actually have quite a bit of fluid in them. So we could think about having high fluid food menus for individuals with dysphagia who are maybe not as interested or can't consume the thickened fluids for a variety of reasons. The reality is, though, they probably can't consume enough of these foods in addition to other nutrient and energy dense foods to meet their needs. So typically the research shows that it's not sufficient to just meet your food requirements through food alone. And then finally, artificial hydration is another option. It's used in some homes, certainly especially for individuals who have chronic dehydration. And it's called hypodermocyclus, basically putting fluid through needles underneath the skin. That's one avenue. And of course, individuals with dysphagia might require at some point in life artificial fluid and nutrition. Certainly in individuals with dementia, though, we do not advocate for the use of artificial fluid and nutrition through a tube. That's not considered an ethically sound practice for individuals with dementia who have dysphagia. In addition to those strategies specific to dysphagia, there has been a variety of strategies suggested to support hydration overall in long-term care. And so these are some of these suggestions on the slide. For example, trying to have continuity of staff. Staff know how much a person's consumed from breakfast to lunch, and they know how they drink and what they like to drink. So that continuity is really important to support hydration. We need to also think about the physical environment to make it promoting for food intake and fluid intake. So in terms of dining rooms, making sure they're not chaotic, that they're actually a place where people can linger and enjoy a drink of tea or whatever it is they're consuming. Smaller dining environments have been suggested as a way to promote food and fluid intake. A social eating environment as well supports intake. So we know that mimicry can really help individuals with hydration. So if someone is sitting in front of them and touches a cup and drinks, then they are more likely also to drink if they have dementia when they see someone doing that. Culturally familiar foods, thinking about that, flexible meal times, staff eating with residents, again, that mimicry idea, and staff education on hydration needs and how much to offer and how to offer that fluid to individuals who might be sippers, for example, and need to be encouraged to drink. And needing to have basically fluid available. You can't drink if it's not offered, as someone recently said to me. So I think it's really important to make sure we have the frequent offerings of fluid during a day to support individuals who have the risk for dehydration. I want to end off with just a few key slides about the idea of balancing quality of life and safety. And so long-term care individuals are often more concerned about their quality of life than anything, but we need to balance that out with safety, recognizing that feeling like you're choking, feeling like you're coughing when you're eating is not a pleasant experience either. So it's really important for practitioners and providers in this area to weigh the risks and the benefits and individualize then the management strategies that they are suggesting for the residential individual person living in residences. We need to think maybe perhaps of a sliding scale with respect to how we will address dysphagia. This, though, again, requires that we have qualified personnel in long-term care to do that. Dietitians as well as speech language pathologists to think about how we can actually do a good job of this, of weighing those risks and what benefits and how we can support the individual as best we can. And as well, recognizing that change happens, right? People might have a bad spell where they need thickened fluids, might be able to go back down a level with respect to going to a thinner fluid. But the point is we need to keep reassessing that resident and training our staff to do so, nursing staff included, because they're there right at the table side, seeing individuals consuming fluids, and they know what's happening and recognize those signs that perhaps something is going wrong, and someone like a speech language pathologist or a dietitian needs to come in and look further at the issue. So in summary, dysphagia is variably assessed and treated in residential care. Dehydration is similarly poorly identified, and we really don't know the prevalence. We suspect it to be quite high, though, for both dysphagia and dehydration. And likely those with dysphagia are at even higher risk of dehydration than their counterparts in the residents who do not have that condition. The topology of fluid intake helps us think about how we can address dehydration and how we can prevent it, and recognize that dysphagia is certainly one component of that topology, but the reality is people might have multiple reasons why they're not drinking well. So you could have an individual with dysphagia who has dementia, also forgets to drink, but also might be a sipper, which means we have to think creatively around how to manage that potential dehydration. There's a variety of strategies available to how to address dysphagia, and thickened fluids being the most common and viable strategy for long-term care at this point in time. We do need more research, though, I think, on normative thick fluids and how they could be introduced into a menu and being used across the entire population in a residence, as well as thinking about how we can bump up the fluid content of foods that are offered to individuals. And then finally, an appeal to remember the resident when managing dysphagia and balance the safety of a safe swallow with quality of life and the needs of that resident. So thank you very much.